Remember, burn patients are prone to hypothermia. We never administer any IM pain medications to a burn patient. We want to assure proper decontamination of all patient providers and equipment and contact the receiving facility as soon as possible. Now, your burn center verifications. VCU is an adult and peds burn center in Richmond, Virginia. Washington Hospital Center is an adult burn center in Washington, D.C. North Carolina JC's Medical Center is adult and peds in Chapel Hill, North Carolina. Johns Hopkins Regional Burn Center is adult in Baltimore, Maryland, and Wake Forest University Baptist Medical Center is adult and peds in Winston-Salem, North Carolina. And of course, remember for our burns patients, because of the distance to these burn centers, air medical transport should be utilized. Okay, Protocol 23 is a new protocol here. It's a carbon monoxide smoke inhalation protocol. And we do have a new medication for our IMP level providers. Hydroxycobalamin is given for cyanide exposure. Let's talk about hydroxycobalamin. Your dose is 70 milligrams per kilogram over 15 minutes. Indications are cyanide exposure. This is the antidote to cyanide poisoning. Hydroxycobalamin works by binding cyanide and forming cyanocobalamin for urinary excretion. Contraindications to administration of hydroxycobalamin is none in the settings of suspected cyanide toxicity. There are some side effects, however: redness of skin and mucous membranes, headache, dizziness, restlessness, eye and throat irritation, dyspnea, pulmonary edema, chest tightness, hypertension, tachycardia, palpitations, nausea and vomiting, diarrhea, abdominal pain, dysphagia, red urine, and hives. Okay, so let's take a look at some of those side effects. We give hydroxycobalamin for a high suspicion of cyanide poisoning. So if this patient was involved in a house fire, inhaled a lot of smoke, a lot of byproducts of combustion, we're going to administer at 70 milligrams per kilogram IVIO over 15 minutes. Maximum dose is 5 grams. We want to consider CO and cyanide with any products of combustion. The first picture here on the left is the reddening of the skin after administration of hydroxycobalamin, and the picture on the right is the urine from that patient after hydroxycobalamin was administered. All right, Protocol 24 is our crush syndrome protocol. So for our advanced through paramedic providers for crush syndrome, it is very heavily focused on fluid resuscitation, normal saline boluses of 1 liter IV, and we want to consider a second line and an additional liter if the patient has been trapped for greater than 1 hour. Now for our IMP level providers, we need to be looking on our EKG for peaked T waves, a QRS that is greater than 0.12 seconds or 3 small squares. So a wide QRS, and the absence of P waves. Okay, so if the EKG abnormalities are present, that is the peak T waves, the wide QRS, and the absence of a P wave, our INP level providers are to administer sodium bicarbonate, 100 milliequivalents mixed in 1,000 mLs of normal saline, and they're going to infuse 100 to 150 milliliters an hour. Calcium chloride, 1 gram IVIO over 3 minutes, and albuterol, 10 to 20 milligrams over 15 to 20 minutes. If no EKG abnormalities are present, but we still have a crush syndrome patient, we need to administer sodium bicarbonate, 50 milliequivalents IVIO immediately prior to extrication. Okay, so for pain management in our crush syndrome patient, the doses are the same: fentanyl 1 to 1.5 micrograms per kilogram, IVIO, IM, or IN. And we may repeat to a max of 2 micrograms per kilogram, and if needed, ketamine 0.1 to 0.5 milligrams per kilogram, IV. Also, Versed or midazolam 1 to 2 milligrams IVIO, IM, or IN for anxiety if needed, and be aware of a possible synergistic effect. Protocol 25 is an extremity injury protocol. No real change from your current protocols in treatment of your patient with injuries to their extremities. Protocol 26 is a head injury protocol. Okay, so within this protocol, there's a reminder that we do not hyperventilate patients. We may only increase ventilations in the instance of brain herniation syndrome. So our normal ventilations, adults 8 to 10 a minute, pediatric 12 to 20 a minute, and infants 20 to 25 a minute, to maintain an end-tidal CO2 normal reading of 35 to 45 millimeters of mercury. Now, if we have a patient with a head injury showing signs of brain herniation, such as unilateral or bilateral dilation of pupils, posturing, decorticate, or decerebrate posturing, we want to increase our ventilatory rate. Adults 14 to 16, peds 20 to 25, infants 25 to 30. And we want to maintain a lower end-tidal reading of 30 to 35 millimeters of mercury. Same thing is true for patients who show signs of increased intracranial pressure, such as Cushing's reflex with hypertension, bradycardia, and irregular respirations. So the reason we do this, why do we increase the ventilations? Well, increasing the ventilations decreases the carbon dioxide level in the body. Carbon dioxide dilates the cerebral blood vessels. If we dilate the cerebral blood vessels, we increase the blood volume in the intracranial vault and therefore increase the intracranial pressure. So we want to keep that CO2 level down. Of course, hyperventilation must be avoided. Okay, Protocol 27 is a multi-system trauma protocol, and it's broken down between abnormal and normal vital signs perfusion and GCS. No real change in your current treatments. Protocol 28 is an abdominal pain protocol. And of course, our chief antiemetic that we're still carrying is ondansetron or Zofran. So just a few notes on abdominal pain. Abdominal pain in women of childbearing age should be treated as pregnancy-related until proven otherwise. The diagnosis of abdominal aneurysm should be considered with abdominal pain in patients who are over the age of 50. And we want to consider cardiac in nature in patients over 50, diabetic, and or women, especially when they have a complaint of upper abdominal pain.